Okay, welcome. My name's Harry Urba. I'm from the University of Alabama at Birmingham. Good afternoon, and thank you for joining us for this educational symposium, a master class on building better therapy for acute myeloid leukemia, making the most out of the increasing number of therapeutic and innovative options that we have. I'd like you to join me for this peer-reviewed live symposium in welcoming Dr. Naval Daver at the end from the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Amir Fathi from Mass General Hospital Cancer Center and the Harvard Medical School in Boston. He's the one sitting in that empty chair right there. And Dr. Michael Savona and Dr. Stephen Strickland, both from the Vanderbilt University Medical Center and Vanderbilt Ingram Cancer Center in Nashville, Tennessee.
The following audio is part of a certified educational activity. Access the entire activity and complete the post-test at www.peerview.com/MJN. Downloadable slides and practice aids are also available.
So what we witnessed this year is something remarkable that AML physicians have been bemoaning for 40 years, and that was most of the advances and new drugs coming to our patients in prior years have been in other hematologic malignancies. So the U.S. new drug approvals in HEMONC in 2015 and 16, as you know, were for Hodgkin's lymphoma, multiple drugs for CLL, follicular lymphoma, 5 drugs for multiple myeloma, mantle cell lymphoma, and ALL. But no therapies have been approved in the United States for AML since 2000 until this summer. And now in 2017, we have the first approval of a FLT3 inhibitor, midostaurin, the reapproval of gemtuzumab ozogamicin, the anti-CD33 antibody drug conjugate, the small molecule inhibitor of the mutant form of IDH2, enasidenib. Some of you may remember that as AG221. And then the liposomal formulation of daunorubicin cytarabine in a fixed molar ratio, what the investigators called CPX351. So we have new drugs that are available to our patients, and the question, of course, that we want to try to address this afternoon is how do we incorporate these therapies into the care of our patients? And so we're going to have 6 master classes on these recent changes. I'm going to start by discussing secondary and therapy-related AML. Then we'll move on to targeting FLT3 mutations in AML. Then IDH1 or IDH2 mutations in AML. Antibody-based therapies for acute myeloid leukemia. And then a role for immunotherapy in the management of AML. Does it exist and what's the data? And then we'll come back to just a little bit of what is the future of targeted therapy in AML, looking at some other targets such as BCL2 inhibition and others. So let's get started, and I'm going to address treatment challenges in secondary and treatment-related acute myeloid leukemia. And as you know, when we see a patient with acute myeloid leukemia, we consider a number of options in trying to determine their prognosis and also pick the best therapy for them among the choices that have been available. In terms of patient characteristics, age has been one that we have used, but it's really become known as a surrogate, advancing age, for other things that affect outcome. Worsening performance status, comorbid illnesses, and functional and cognitive status. We also know that the biology of the disease can help determine prognosis, and we believe also helps to shape our therapeutic approach. And so in terms of the history of the patient, we've been looking for antecedent hematologic disorders such as MDS, treatment-related disease. And then in terms of the biology of the disease, the white count at presentation has been found to be very important, and then cytogenetics and molecular abnormalities. But let's look at the middle of that table, antecedent hematologic disorders and treatment-related AML. How common is this? This is registry data from Sweden showing that a significant minority of patients in the orange and green had secondary or treatment-related AML over the 13 years of this registration. And those patients who had secondary AML, whether with a preceding MDS or a non-MDS hematologic malignancy or treatment-related AML, all the lines except the blue one, did worse. We also know that the incidence of secondary acute myeloid leukemia increases with advancing age. So in this entire registry, again from Sweden, about a third of patients had either an antecedent hematologic disorder or treatment-related acute myeloid leukemia, and the rest were considered de novo. But the incidence appears to increase with advancing age, as you might expect in terms of treatment-related and also the natural history of myelodysplastic syndrome. But whether a patient has treatment-related AML or secondary AML as a younger patient or an older patient, the impact on the prognosis of these patients is similar. These patients do less well, even though the intensity of our therapies and our therapeutic options might be different. So let's get back to these traditional and prognostic factors and try to roll into this some of the newer ones. Now, we know that we've been using cytogenetics for many years. The favorable risk cytogenetic changes, the core binding factor leukemias, and then a large group, 25% or so of patients of poor risk cytogenetics, typically complex numeric or structural changes in the chromosomes, monosomal karyotypes, chromosome 5 and 7, deletions, either complete or partial, MLL gene rearrangements in version 3 and the 6-9 in the Philadelphia chromosome. We also have learned with the advent of more detailed molecular data from our patients that mutations, single gene mutations, are quite important in determining prognosis. Patients with nucleophosmin mutation or biallelic CBP alpha mutations with a normal karyotype have outcomes that are similar to those with core binding factor leukemia. Patients who have P53 mutations or patients with a normal karyotype with FLT3 internal tandem duplications have a much worse outcome, and we're including this information now in our prognostication. And this information is not separable easily from the clinical history of an antecedent hematologic disorder or treatment-related disease, because many times those patients with that history will have P53 mutation or complex poor risk cytogenetics. We know that the incidence of adverse karyotype goes up with advancing age. This has been shown in SWOG data, but here you see MRC data. And the number of patients with favorable risk karyotypes goes down with advancing age. We've also learned that there appears to be a certain molecular ontogeny that can identify secondary acute myeloid leukemia. This data comes from a study that I was involved with, among others, obviously, multi-center trial looking at a modified versus daunorubicin in patients with clinically defined truly secondary AML. And what the investigators at the Dana-Farber did, and this paper was published by Coleman-Lindsley, is they did a molecular analysis and compared the mutation seen in that cohort to patients who apparently had de novo AML. And they found about 8 mutations that seemed to be more specific for secondary AML. And they fall into basically 3 classes: the spliceosome mutations, chromatin modifying enzymes like EZH2 and ASXL1, and then also cohesin mutations such as STAG2. Well, what they did with this information is they then went back and looked at patients who were treated locally who apparently had de novo AML and without a clinical history of MDS or treatment. And they found that patients who had P53 mutation or secondary type of AML with those 8 mutations I just mentioned had not only a lower complete remission rate, but as you can see here, a worse survival. This is also true for P53 and other data sets. P53 mutation is a poor risk feature in patients with complex karyotype and non-complex karyotype as well. And you can see patients with complex karyotype, where about 60 to 70% might have a P53 mutation, have a very poor outcome as shown in light blue. So let me turn to how this information now is incorporated into the World Health Organization classification of acute myeloid leukemia. The WHO classification is really a hierarchical system. You'll remember that the first category is AML with recurrent genetic changes, core binding factor leukemias, and so on. But then the second large group are patients with AML with myelodysplasia-related changes, which is defined as AML with either a history, a documented history of MDS, or specific MDS-MPN overlap syndromes such as CMML or atypical CML, Myelodysplasia-related cytogenetic abnormalities, of which there's a long list. I usually just can remember in my head the complex karyotypes, monosomal karyotypes, and chromosome 5 and 7 abnormalities, but there are others. And then the morphologic description, where at least 50% of the cells in two of the myeloid lineages at least, have dysplastic changes. And this has been modified in 2016, and the reason for that is that when this first came out in 2008, there were retrospective studies looking at the validity of that subtype as maybe implying a worse outcome. And with intensive chemotherapy, patients who had MRC, as listed here, only on the basis of dysplasia, did just as well as patients with other AMLs not otherwise specified. And it was really the subset of patients with an antecedent hematologic disorder or the cytogenetic changes who had the worst prognosis. With subsequent analyses, we've learned that the genetics really outweighs the morphology, and patients can have dysplasia, but also have favorable risk mutations such as core binding factor, cat enhancer binding protein alpha biallelic mutations, or nucleophosmin mutations. And so this has been included in the classification. If a patient has MRC based on dysplasia, they cannot have one of those good risk molecular features. The third major category is therapy-related AML. It accounts for about 10% or so of patients with acute myeloid leukemia. And I tend to think of it as coming in two flavors. The alkylating agent or ionizing radiation-induced. These patients typically have a smoldering history of cytopenias, a preceding myelodysplastic syndrome, a longer latency, 5 to 10 years, but there is no lower limit and no upper limit on how we define the association. And typically when we do cytogenetics, you see complex numeric or structural changes in the karyotype, especially with deletions in chromosomes 5 and 7. Now the other flavor are with the topoisomerase II inhibitors. So these are the anthracyclines, the anthraquinone mitoxantrone, the epipodophila toxins like etoposide. These patients typically show up with acute myeloid leukemia without a preceding MDS, a much shorter latency of 1 to 3 years, and the most common rearrangement is in the MLL gene on chromosome 11, band Q23, often with a monoblastic morphology. But I will caution you to remember that there are also treatment-related AMLs due to topoisomerase II inhibitors that have other translocations, which can be things like inversion 16 and the 821, typically better risk cytogenetic changes, and PML-RAR alpha as well. And although the literature is a little confusing on this point, at least myself, I see a lot of these, quite a few of these patients who can have long-term good outcomes with just standard chemotherapy. So let's turn our attention now to the older acute myeloid leukemia patients where secondary AML and therapy-related AML is more common, and look at which patients receive chemotherapy to treat this disease. And as you know, even with this more modern recent update of SEER and Medicare data, it's still only between 35 and 40% of Americans over the age of 65 who've received any form of therapy. Now, over the years, the number of patients receiving hypomethylating agents has increased during this time period. But it's the same factors that we are recognizing in our clinic that have help determine which patients do get selected for therapy. So it's a busy table, but what you can see here is that age, advancing age, less patients receive therapy, patients with worse performance status are less likely to receive therapy, and patients with an antecedent hematologic disorder. And yet, we have seen from this retrospective data that therapy is associated with better survival. So how do we approach this group of patients? And I'm going to take this discussion from the point of view of current NCCN guidelines, spending most of the time looking at patients over the age of 60. So if you take this page from the NCCN guidelines published this summer, 2017, you can see that in some way we make a clinical decision whether the patient is a candidate for intensive remission induction therapy or not. I am not today going to speak about the patients who are not fit for intensive chemotherapy. I'm going to focus the rest of my comments on those patients who you are going to try to treat with chemotherapy. And the NCCN divides this group of patients into those who are better risk and those who are worse risk. So it predisposes that you have this information when you start therapy. So a patient with de novo AML without unfavorable karyotype, without unfavorable molecular markers such as the ones identified in the paper by Lindsley and others, no antecedent hematologic disorder, or no therapy-related AML. It's either a clinical trial or I will just summarize that box as saying 7 and 3. On the other hand, patients with de novo AML and unfavorable karyotype, poor risk molecular markers, antecedent hematologic disorder, or therapy-related AML, there are a number of options that are listed there by the NCCN. Clinical trial, lower intensity therapies, and I'll show you a little bit of data on that, standard dose cytarabine and anthracycline or anthraquinone, and now with the FLT3, the data with midostaurin, which we'll hear, adding midostaurin, and also clofarabine is still listed. So let's look at some of the data that supports this recommendation. Well, there's been a lot of interest in clofarabine as a drug for patients with, who are less fit or less responsive to chemotherapy, phase 2 data that's been published. But James Ferran and ECOG led a multi-center trial of 7+3 versus single-agent clofarabine, followed by intermediate dose Ara-C for the 7+3 or 2 cycles of clofarabine. And this data has now been presented. I'm showing you subset analyses. Those patients without therapy-related AML, basically de novo AML, had a better survival with 7 and 3, but there was no benefit of clofarabine in the treatment-related AML. And likewise on this slide, no benefit of clofarabine over 7 and 3 in the table on the right, those with an unfavorable karyotype. How about the hypomethylating agents? And again, I can't summarize the entire experience with this that's been published, but let's look at the AML 001 study. Now, this is for patients over the age of 65 with newly diagnosed de novo or secondary AML with adequate performance status and intermediate or poor risk cytogenetics. And as you remember, these patients were randomly assigned to either azacitidine or a conventional care regimen pre-selected by the investigator and their patient, either intensive chemotherapy, low-dose cytarabine, which was about 2/3 of patients, or best supportive care. And the fact that patients received intensive chemotherapy suggests that these patients must have been felt to be, at least some of them, eligible for that. The two groups were well balanced, median age is 75. What you can see here is that about 1/3 of patients had myelodysplasia-related changes, and about 1/3 of patients had poor risk karyotype. As you remember, there was a trend for an improvement in median survival with azacitidine at 10 months versus conventional care regimens of 6.5 months, and at 1 year, more patients were alive who had been randomly assigned to azacitidine, 46% versus 34%. But unfortunately, you could also see these curves come together at a very low level of about 10%. But when you do a subset analysis that look at patients with myelodysplasia-related changes, there does appear to be a benefit of azacitidine over those conventional care regimens, and the same is true for poor risk cytogenetics. Again, the curves coming together. So let's turn to a patient. This is a patient that I've seen in my clinic recently, a woman diagnosed with low-grade myelodysplastic syndrome, intermediate 1, in 2013 at the age of 65. She was treated with azacitidine. I'm not quite sure what was the initiating reason for that, but she received 19 cycles. After the azacitidine was stopped, she was diagnosed with an invasive colon cancer, early stage, developed neutropenia, then went on to develop pancytopenia this year. Bone marrow biopsy showed acute myeloid leukemia by morphology and immunophenotype. You could see she was pancytopenic. Next-gen sequencing panel showed 5 different mutations, including a couple from that list that are part of secondary AML, the spliceosome mutation SRSF2 and the chromatin modifier ASXL1, and also RUNX1, which has been associated with a poor prognosis, but the karyotype was normal. I chose to treat this patient on label with the drug we're going to be talking about, that's liposomal daunorubicin cytarabine. She received that, she was actually admitted for it because when she presented she had febrile neutropenia and a port infection. She cleared her marrow at day 14, received tebofilgrastim for neutrophil recovery, and she achieved count recovery good enough to get out of the hospital by day 27. And on follow-up, this was a little bit over a month after starting treatment, her bone marrow was clear of leukemia. In fact, by day 35, a little bit after that bone marrow, she had recovered her count. She's getting outpatient consolidation with CPX 351 and is being considered for allotransplant. So let's talk now about daunorubicin cytarabine. This is a liposomal form of daunorubicin cytarabine, but what you need to remember is that this is a fixed molar ratio of daunorubicin to cytarabine, a 1 to 5 molar ratio, and this has been chosen because of in vitro models and animal models showing that there's synergy between daunorubicin and cytarabine at this molar ratio. Well, how do you maintain that molar ratio in patients being treated with those two drugs? You have to encapsulate them in a liposome. And what's been shown is by doing that, you can ensure a fixed molar ratio being delivered to the bone marrow more consistently over a 24-hour period. And the liposome appears to be important because in preclinical models, it appears that the bone marrow is more targeted than other organs, in preclinical models at least. So this drug has now been approved in 2017, and it's based on a phase 3 study we're going to talk about. Now, that phase 3 study was informed by a prior randomized phase 2 study in previously untreated older AML patients, where there was no benefit for the whole group of CPX 351 over 3 and 7. But in a subset analysis, the response rate appeared higher, the event-free and overall survival were better for patients receiving CPX 351, and this was not at a cost of more induction mortality. And so this informed a large phase 3 study shown here, which has led to the FDA approval. So this is for patients between the ages of 60 and 75 with previously untreated AML who can tolerate chemotherapy. Okay, these are not unfit patients. They had to have therapy-related AML, AML following an antecedent hematologic disorder such as MDS or CMML, either pre-treated with an HMA or not, or de novo AML with a MDS-like karyotype. They were randomized to get CPX 351 as an IV infusion on days 1, 3, and 5 versus 7 and 3 using daunorubicin at 60 milligrams per meter squared. If patients had cytoreduction at day 14, they could get an abbreviated course of either, and if they achieved a remission, they would go on to get either 2 cycles of CPX 351 or 2 cycles of 2+5, which is in NCCN Guidelines as an acceptable post-remission therapy for older patients. And of course, patients who were deemed eligible for transplant could go on to transplant. Well, here's the data that I'm going to show in the next several slides. The response rates were statistically higher with CPX 351 versus 7 and 3. You see for CR rates 37 versus 26%. But the primary endpoint of the study was met, and that was survival. The survival with CPX 351 was 9.5 months median survival compared to 6 months with 7+3 for a hazard ratio of about 0.7, and this was statistically significant. The other thing that I like to look at in these curves is that there aren't many patients out at the tails, but the tails haven't come together yet. In a subset analysis based on the stratification, the benefit was seen in the older patients, 70 to 75. You could see 8.9 versus 5.6 month median survival. More patients went to transplant after CPX 351, both in the younger and in the older age group, 70 to 75. And the patients who went on to transplant after CPX 351 had a better survival than patients who went on to transplant after 7+3, and I think we have a lot to learn about why that might be. When you look at survival in these two arms for treatment-related AML, again, a benefit. This was not at a cost of higher mortality. In fact, the mortality was lower with CPX 351 than 7 and 3, both at day 30 and in day 60. Now, the mortality due to adverse events related to therapy were similar. The extra mortality in the 7+3 arm appeared to be due to persistent leukemia. However, this has a toxicity profile very similar to 7+3. In fact, there were slightly more grade 5 CNS hemorrhages due to in the CPX arm, 2% versus 7+3, where it was 0.7%. And there was more delayed count recovery, which this slide attempts to show you. There was the median time to ANC over 500 with CPX 351 after induction was a median 35 days versus 29 days. And you can see similar data for platelets. So I'm going to close now with just a comment about, well, how about the younger patients, because the younger patients, all adults are included in the label. Now in the randomized phase 2 data, there wasn't a worse outcome in younger relapse patients who received CPX 351. But the question is, what would we normally do for a younger patient with acute myeloid leukemia? So again, I've shown NCCN guidelines here. And its clinical trial, standard dose daunorubicin, cytarabine, you can add a FLT3 inhibitor, or you could think of a flag-like regimen or a regimen with high-dose Ara-C, and you can see there a Category 1 recommendation. That recommendation for high-dose Ara-C for the younger patients comes from this study from the EORTC that looked at 2,000 patients who were randomly assigned to get daunorubicin and etoposide with either standard dose cytarabine or high-dose cytarabine, 3 grams per meter squared for 8 doses. And in the patients who were under the age of 45, you could see the survival was 52% versus 43%, and there appeared to be a benefit of the high-dose Ara-C in the secondary AMLs. But the point I'm going to make here is that there's amazingly very little data to show that more intensive therapy, even in younger patients, is beneficial for patients with secondary AML. So what are we left with now? I think the next questions in secondary AML based on this data are the following. I think we need to know a lot more about the benefit of CPX 351 defined by cytogenetic and molecular subsets. The clinical history is important, but we all feel that the genetics of the disease is what's really driving the outcomes. We also have to look at the comparator for CPX 351. 7 and 3 and 2 and 5 are accepted comparators in older patients, but NCCN says you could use hypomethylating agents. And so maybe we should be looking at CPX 351 versus hypomethylating agents in the older patients, and likewise in younger patients, maybe comparing CPX 351 to a more intensive regimen. And then, of course, we're going to have to figure out what to do with all of these new drug approvals, some of which you'll be hearing about, in terms of addition of these agents to CPX 351. And why is there a benefit of CPX 351 prior to allotransplant? One hypothesis is maybe it's better at clearing minimal residual disease, but we don't have that data yet.
So first of all, just to say thank you to the organizers as well as Dr. Rube and all of you, of course, for your presence here today. All right, so we'll go ahead and get started. We'll start off with a case. A 49-year-old female who presented to their primary care physician for evaluation due to pre-syncopal symptoms that they were having. Medical history did not seem to be overly contributory, just some menopausal symptoms, vertigo-type symptoms, and the patient had had a prior cholecystectomy as well as hysterectomy. The review of systems for the patient indicated that she was having some easy bruising and gingival bleeding with mouth care. The evaluation of this patient's peripheral smear did indicate the presence of leukocytosis as well as anemia and thrombocytopenia. And the peripheral smear also demonstrated the 69% blast, and it was reported that upon the morphologic assessment that there was some thumbprinting appearance of the nuclei. A bone marrow biopsy was performed, 72% blasts were identified, and the following immunophenotype and a normal karyotype. Now we know with the availability of additional information, these patients who would have previously be put simply into an intermediate risk cytogenetic risk category based on normal karyotype, we now have additional information with the molecular profiling that should be obtained to help us tease out the further risk stratification of these patients and also potentially identify therapeutic targets. This patient's molecular profile did demonstrate the presence of a FLT3 internal tandem duplication with a high allelic ratio of 0.89, as well as the presence of NPM1 and DNMT3A mutations. And this, again, I will reiterate, as Dr. Rube mentioned earlier, is important due to it affecting the therapeutic choices that we now have upon us, as well as potentially impacting the decision to take the patient to transplant in the first remission. So we've had sort of an explosion of available testing that can now be done with various next-gen panels and various panels that are available, and it seems like every day a new report is coming out about a new prognostic marker. And you can see here between the FLT3 mutations, NPM1, IDH, BCL2 expression, and on down the list, that we now have the biologic proof to understand that AML, although it looks very similar under the microscope, is an extremely heterogeneous disease, and we need to do better. Instead of treating everyone with 7+3, try to hone in on these abnormalities and figure out the best way to treat these patients more precisely. So this is data that was generated by our colleagues at MD Anderson, looking at the overall survival of patients with FLT3 mutated AML, and looking at it over different eras. And we can see that patients who were treated early in the early 2000s did quite poorly with this disease. And then I think as we began to see that, treating physicians were more aggressive with potentially taking these patients to transplant. And then as time went on, we began to have FLT3 inhibitors available to us in the context of clinical trials or possibly even off-label use of sorafenib and et cetera. And we started to see improvements in the overall survival. We should also mention that although a lot of the original data regarding the FLT3 mutations was first highlighted in the normal karyotype group, there was information and data that was presented by the UK MRC group that indicated the impact of FLT3 amongst the various cytogenetic risk groups, not just limited to normal karyotype. And as you can see, patients in each risk category who had the presence of a FLT3 ITD did more poorly than the corresponding group that did not have the FLT3 abnormality. So FLT3 mutations, FLT3 ITDs occur in approximately 25% of patients. It is associated with a poor prognosis and an increased relapse risk. As far as the FLT3 TKD or point mutation or D835 as you may know it, it occurs in only about 5 to 10% of patients, and its effect is largely unclear in regards to prognosis. I think you can find various reports that say it may confer a poorer prognosis, but that data is still emerging as far as for its universal acceptance of how to act upon it. FLT3 mutations, the downstream effects of the FLT3 wild type is critical signaling molecule in myeloid development, and it's also associated with increased downstream signaling to promote survival and proliferation. So FLT3 inhibitors that have been tested so far in AML, this was first sort of identified with the ability to inhibit FLT3 with staurosporin, which was a natural product that was isolated. Midostaurin is a multi-targeted tyrosine kinase inhibitor with potency across several classes, including FLT3, ITD, TKD, as well as KIT. Quizartinib, which you are also likely familiar with, is more potent in regards to hitting FLT3, but it targets only FLT3 and resistance occurs through various point mutations. The crenolanib and gilteritinib, which aren't shown in this slide here, are also very potent with fewer off-target effects than midostaurin, and they also inhibit the TKD mutation. Both of these drugs are in phase 3 development, or including also the quizartinib. I'm going to talk briefly about the phase 3 Ratified Trial. This was a study where treatment-naive patients with activating FLT3 mutations were randomized to receive either conventional chemotherapy with or without midostaurin. The cytarabine dose was 200 milligrams per meter squared, Dono at 60 milligrams per meter squared. Those patients who did achieve CR could go on to receive high-dose cytarabine consolidation plus or minus midostaurin based on the group that they were originally randomized to. And I also want to highlight the issue that this study was designed and conducted that patients who were not taken off study to go to transplant were given the opportunity to receive continuation therapy of up to 12 cycles of midostaurin versus placebo maintenance. I want to highlight that for just a second because the label indication actually does not include maintenance in the prescription of the medicine, although that is the way this study was conducted. The baseline characteristics of the patient were largely balanced, although there was a statistically significant difference in the number of female patients who were placed in the placebo group relative to the midostaurin group. Also looking at the balance between the various risk classifications based on ELN, cytogenetic abnormalities, the white blood cell count, as well as platelet count and neutrophil count. Now, the complete response data that was seen in these patients, and initially CR by day 60 was noted, which was specifically defined within the study, occurred in 59% of patients in the midostaurin group relative to 54% of patients within the placebo group, and this difference was not found to be statistically significant. However, patients who had complete remission with incomplete count recovery were also allowed to go on to consolidation therapy, and as you see lower, those patients who potentially went on to consolidation with incomplete count recovery who subsequently recovered their counts further with additional therapy led to a CR rate of the midostaurin group compared to placebo that was statistically different. As far as the safety profile, the adverse events with a significant difference between midostaurin and placebo, draw your attention to anemia, and this is the grade 3 or higher adverse events. Anemia was seen as a statistically significant increase within the midostaurin group, and jumping down to the non-hematologic adverse events, we see that rash also developed amongst the patients with midostaurin, and interestingly enough, nausea was increased in the control group. And I think that's quite peculiar because I would have anticipated and bet that it would have been the opposite based on the earlier data indicating that one of the limiting toxicities from midostaurin at higher doses was actually GI toxicity. But when they analyzed the data and at this dosing level, the placebo arm actually had more nausea than the midostaurin group did. Now, if we look at the survival outcomes and transplant rate, the overall survival with the addition of midostaurin led to a median survival of 74.7 months compared to 25.6 months. That was statistically significant, as you would expect. Transplantation that occurred in the first remission, more patients within the midostaurin group were taken to transplant in first CR. The overall CR rate was also increased within the midostaurin group at 58% compared to 54% in the placebo group. And the 4-year overall survival among patients who went to transplant was also higher but did not reach statistical significance. In regards to event-free survival, we also see that the addition of midostaurin led to statistically significant changes in event-free survival of 8 months compared to 3 months. As far as post-transplant survival, we also see that the addition of midostaurin, as well as taking these patients to transplant within the first remission, led to superior outcomes. I think this is an interesting slide as well to kind of do the breakdown of patients not only with FLT3 ITD, but also those with high allelic ratio, lower allelic ratio, as well as the presence of the tyrosine kinase mutation. And in each group, you can see that the corresponding group that received midostaurin compared to its counterpart that received placebo, the midostaurin led to improvement across the board. So we're going to switch to a second case that we'll briefly talk about, which involves a 62-year-old man with a history of FLT3 ITD AML that was identified at his initial diagnosis. He was diagnosed in January of this year, prior to the availability of midostaurin from commercial availability. He was previously treated with 7 and 3, achieved a remission, went on to receive 4 cycles of consolidation therapy, but unfortunately presented very shortly thereafter completing therapy with fevers, shortness of breath, fatigue, and gingival hyperplasia. This patient had a very high white count at the time of presentation, as well as anemia and thrombocytopenia, and the peripheral smear demonstrated the presence of blasts that were reported to have a cup-like appearance. And both the thumbprinting as well as this cup-like appearance can sometimes be commented on by our pathologist and may represent patients with FLT3. This is not a one-to-one association. Patients with NPM1 abnormalities may also have some of these changes, but if you see these changes, it may increase your suspicion that a FLT3 abnormality may be present. So this patient at the present time would be a candidate for enrollment onto clinical trials looking at FLT3 inhibitors. As we know, midostaurin is approved in the frontline setting. This patient is obviously relapsed, and there are several agents in development in the relapse refractory setting with very promising activity, and I would encourage hopefully this patient being evaluated for one of those trials. As we look at the medications that are further on in development, quizartinib as well as crenolanib and gilteritinib, there are some similarities, but there are also some unique differences in the sense that the dosing is once daily for quizartinib and gilteritinib. However, crenolanib has a short half-life and does require dosing at 3 times daily. The crenolanib as well as gilteritinib have D835 or TKD activity, whereas quizartinib does not demonstrate activity in that setting. Now, single-agent studies have been done or are open amongst these. The frontline chemotherapy, the quizartinib trial is ongoing. The crenolanib and gilteritinib trials are planned and should hopefully be opening and available soon for our patients. There's also trials that are being conducted with post-transplant maintenance. So the availability of these agents for many of our patients who have FLT3 positivity and are relapsed or post-transplant, hopefully we can make this available to them. I'd like to talk for a few minutes about some of the quizartinib data and the relapse refractory population, and these are the results of the phase 2 trial. So this has demonstrated that the presence of quizartinib in the FLT3 ITD as well as FLT3 negative patients were also allowed early on in the study, and 70% of patients achieved at least a PR if they were FLT3 ITD positive, compared to 55% of patients who were FLT3 negative. And I think the fact that we're seeing any responses amongst the FLT3 negative is interesting, but it also goes to say that these drugs hit many other targets other than just the FLT3 abnormality. This is sort of updated data when more patients had been enrolled into the trial, indicating that the cumulative composite CR rate amongst the FLT3 ITD positive patients was 54% compared to 32% within the negative population. If we look at overall response with the composite CR plus the partial remission, we're approaching 72% of patients within the ITD population that did have response. We also look at the median overall survival unfortunately in the form of weeks, but 25.3 weeks, but there also appear to be survival with those patients, FLT3 ITD negative patients as well. So looking at the survival in the relapse patients compared with historical control. So now it's one thing when we have these single-arm studies, another thing to try and say, well, what does this mean? And obviously the phase 3 trials are ongoing, but looking at the patients who were treated on the AC220-002 trial, comparing them to sort of matched, if you will, controls from historical results, we do demonstrate that across the board, the patients with relapsed post-transplant disease who relapsed after salvage therapy or who were refractory after salvage therapy all seem to have improved survival compared to their historically matched counterparts that did not receive the drug. I just want to draw your attention that a phase 3 study with quizartinib versus chemotherapy in the relapse refractory FLT3 mutant AML population has now completed enrollment, so we'll be looking forward to the readout and the data from this trial. This was oral quizartinib as a single agent compared to salvage chemotherapy with investigator choice of the options that you see there. Primary endpoint was overall survival. This is specifically in the newly diagnosed population, so not pertaining directly to the trial that I mentioned, but since it's relative to the agent, I wanted to bring your attention to it. In regards to gilteritinib and the relapse refractory AML population, I want to highlight this part of the phase 1-2 study that was done. I think this was a very unique design in that the phase 1 and 2 enrolled simultaneously. So once a cohort was cleared in phase 1, the expansion or phase 2 portion was allowed to begin enroll, and the next cohort of phase 1 at the higher dose level was also enrolling at the same time. And so there's quite a few patients that were treated with this agent. You can see that the 200 milligrams as well as 120 milligrams were expanded for further evaluation with an additional 40 patients based on responses that were seen. And if we look at this, we can see in the full analysis set of patients who had FLT3 wild type as well as FLT3 mutation positive patients, and also looking at the patients who were treated with 80 milligrams and above of gilteritinib, and seeing that the responses were seemingly quite impressive for single agent activity in this study in that population who were FLT3 mutated. And if we try to break down the response by dose and TKI status, the overall survival with gilteritinib, the patients who had more than 80 milligrams daily appeared to have better survival than those patients who were treated at lower doses. And also looking at the patients who were TKI naive versus those who had had prior TKI therapy. Now, I think this is interesting data, but also now with the availability of midostaurin, we also know that we're probably going to be seeing fewer potential patients who are TKI naive, but this agent does obviously have activity in those patients who were previously treated with other tyrosine kinase inhibitors as well. The gilteritinib data also has done some subset analyses in looking at the patients who had evidence of molecular responses and trying to quantify not just morphologic responses, but also reductions of the detectable FLT3 ITD signal. And those patients who had major molecular responses and who achieved complete remission, the median survival was not reached among those patients. However, those patients who had incomplete count recovery or patients who did not achieve a major molecular response, their survival, as you can see there, I think it's still quite impressive, but there does seem to be improved survival with the deeper responses that can be achieved. A phase 3 study with gilteritinib versus investigator choice, similar to the quizartinib study that I had shown previously, is also currently enrolling and ongoing. Hopefully within the next several months or so, this will complete its enrollment and the data will be available thereafter. Also studies utilizing, as I mentioned, gilteritinib maintenance after CR1 for FLT3 mutated AML as well. And just briefly, I want to close up by briefly mentioning the crenolanib, which is a potent pan-FLT3 inhibitor. It does hit both the internal tandem duplication as well as D835. It is rapidly absorbed. It does have a short half-life. As I mentioned, it does end up requiring 3 times daily dosing. But I think you can see also some impressive responses. Now, I will say in the left-hand side, the charts that you see, cohort A were treatment-naive patients. Cohort B, or the yellow bar, were patients who had received prior TKIs, but amongst them you can see the responses in regards to the survival that was seen as a single agent in the relapsed refractory population. This agent has also been used in newly diagnosed FLT3 patient with data that was presented by Eunice Wang in combination with cytarabine and daunorubicin. So the progress as far as the development of FLT3 inhibitors, we're seeing this area kind of explode. There's a lot of different agents that are out there in development. Obviously the ones that I mentioned that are fairly far along in development, but some that are still in the early phases. So there's a rich pipeline of agents. Hopefully we will ultimately end up with the best one and significantly improve the survival even further in this patient population.
Good afternoon. So I'm Michael Savona, also from Vanderbilt. I'm going to be talking about IDH today. If you've been to ASH the past few years, you've seen this figure from Arul Chennaiyan's Nature Medicine paper several years ago. This has been a very hot topic, and just to remind everyone, isocitrate dehydrogenase is an important enzyme of the citric acid cycle, and this is isoform that's involved in the TCA cycle in the mitochondria is IDH2, and the isoform in the cytosol is IDH1. And when these are mutated, there is an overabundance of a protein called 2-HG, which acts as an oncometabolite, ultimately altering DNA methylation and other epigenetic function and blocking ultimately cellular differentiation. So the prevalence of IDH2 is as follows: about 15% of AML, a smaller but pertinent number of patients with MDS or MDS-MPN overlap syndromes, some patients with angioimmunoblastic NHL, a rare aggressive non-Hodgkin's lymphoma. And then IDH1 mutations are more common in solid tumors, GBM and chondrosarcoma, and less common in AML, but we still see them in AML and other myeloid disorders as noted here. To kind of break that down a little more succinctly and a little more detail, there was a review done of 826 AML patients, and we found 20% of them were IDH1 or 2 mutated. Now, the IDH2 mutants are largely arginine 140 residue or arginine 172 residue mutations, and the grand majority of the IDH1 mutations are all R132, so that's actually informative with the therapy that's being designed. These mutations are associated with older age, diploid cytogenetics, often FLT3, interestingly, and they don't usually occur in relapse when they weren't present to begin with. In other words, they're known as founder mutations. So if you have this a wild type IDH at diagnosis, you're unlikely to develop it later, and that's important when we think about the utility of next-gen sequencing and so forth. So in IDH2, there's one drug, and I'll be talking about enasidenib. This is now FDA approved. And then in IDH1, there's several compounds. There's 3 remaining. Forma's compound FT2102, which is in clinical trial. Bayer's BAO32, which is being tested in solid tumors. And ivosidenib, which is being tested in IDH1 mutant myeloid disease and is the farthest along. So enasidenib, the IDH2 inhibitor, this is from presented last year at ASCO, and it has been since published in Blood by Eitan Stein and colleagues. And there was, in this study, a dose escalation cohort of 113 patients with advanced hematologic malignancies who received drug over 28 days from a range of 50 milligrams to 650 milligrams a day. In the expansion cohort, it's rather interesting. There's 4 different cohorts: relapse refractory older patients, maybe even relapse after post-transplant, relapse refractory younger patients, but specifically excluding transplant patients, untreated patients who either declined or were unfit for induction chemotherapy, and then anybody else if they had the IDH2 mutation. In the phase 2, the recommended dose was 100 milligrams a day in relapse refractory AML. And the endpoints here were safety, tolerability, establishing an MTD, and then secondary endpoints of response, overall response, which I'll go over in a moment. So you can see those 3 phases of that phase 1-2 study kind of listed in columns here, and with the baseline characteristics, they're relatively similar throughout. I'd just like to point out a few things that, as I noted in the beginning, these IDH2 mutants are typically R140 or R172 mutants. And here you can see in this analysis, this was a 3-to-1 ratio of R140 over 172 really throughout the study. Most people who went on the study were performance status 0 or 1. There were a few PS2 patients. The number of prior treatments is appropriate for the phase of the study as I outlined to you. These are pretty poor risk patients. They were mostly intermediate risk. However, if you look at the prior therapies and the type of AML they had, a large number of the patients were refractory through their initial induction or double induction. They relapsed within a year of therapy, about 10%, and then a 10 to 15% relapse post-transplant, which is a pretty miserable cohort. The presence of other occurring mutations for both the R140 and the R172 are listed here, and you can see a theme. Some of the mutations that were mentioned earlier today already, splicing mutations such as DNMT3A, and there's RUNX1, ASXL1. There were more mutations seen in the R140 group of patients than the R172 patients, for whatever that's worth. This is a very well-tolerated drug. These are the treatment-emergent adverse events listed that occurred in greater than 20% of patients. And you'll note a considerable number of patients with hyperbilirubinemia, which remains something that we need to look out for when using this drug. You'll also note that, though not a lot of grade 3-4, quite a bit of cytopenias. Most of that's not treatment-related. It's always tough in an AML study to attribute cytopenias. So the responses are listed here, and this is from the publication in Blood this summer, where you can see an overall response rate of about 40%. Now, mind you, that overall response rate includes what was counted as a part of best response MLFS, which some might not consider part of clinical benefit, yet the blasts were cleared in those patients without recovery of counts. Still, 30% of patients with a PR or better, which ultimately led to the approval of this drug. The median survival, remember, in this very tough group of patients was 9.3 months. But the patients who responded, as you would presume, had a very nice disease-free interval with a median overall survival approaching 2 years and 19.7 months. And even the patients who had some non-clear CR, but a CRI or a PR, had a prolonged disease-free survival and overall survival, noted here. Now this is a little bit of a busy figure also from the publication. I'd just like to draw your eyes to the red, which is CR, and you can see that that bar continues to grow up until cycle 6, cycle 7, where it peaks. And what this means is that patients won't achieve CR necessarily with one cycle, but continue to have improvement. And if they don't have a toxicity of the drug or clear progression, it's important to stay with the drug so that you're able to actually determine if they can reach that maximal benefit, which may not occur until as much as a year or longer. Now, this is an example of a morphologic CR as early as cycle 3, day 1, so it can occur earlier, where you can see nice differentiation of the cells in the panel on your right. But on fluorescence in situ hybridization, you can see persistence of, you'll have to trust me, the R140Q clone in this patient. So despite a morphologic remission, the clone persists in the patient that received the drug and was counted as a CR. And so that led to the question of whether the presence of the clonal burden could affect whether the patients would be more likely to be in a CR, and or the amount of oncometabolite 2-HG that's produced. And if you look on the left, you can see R140s are in this a little bit of a busy figure, but R140 mutants are in the blue squares and the red triangles of the R172. And you can see that regardless of your 2-HG level, it didn't really pertain to how you were going to respond. Likewise, the variable allele fraction did not accurately predict response, although it's worth noting that the bone marrow of the patients with R140 in the far right of the figure tended to show a higher clustering of patients with high allele burden in the non-response column. So this drug was approved based on the phase 2 data with the promise that a phase 3 study would be undertaken, and that's currently in the works. And that's on clinicaltrials.gov in your slide set. So this is a patient who's a 68-year-old woman who received 6 cycles of azacitidine up front. Her performance status upon original presentation was really more like a 2. She didn't want induction chemotherapy, so she was treated with azacitidine at her outside facility. She came relapsed refractory to CS with a PS of 1. And a bone marrow was conducted. And the bone marrow showed 50% blasts in the presence of a leukocytosis and anemia and thrombocytopenia. So next-gen sequencing revealed an IDH2 mutation, the R140Q mutation. So the patient was started on enasidenib at 100 milligrams a day and achieved a CR after 5 cycles of therapy with enasidenib, and an improvement of ECOG performance status, rendering her then eligible to proceed on to allogeneic stem cell transplant. It's important here to remember that some of the responses may not occur up front. She had her deepest remission at 5 months and held that till transplant. She also, in her first couple of months, developed dyspnea, rash, arthralgias, and was found to have an IDH differentiation syndrome. And in that case, the proper treatment is to initiate steroids, monitor very closely, treat like an ATRA syndrome, and potentially even hold drug while this clears up. So moving on to IDH1 inhibitors. So FT2102 is a compound currently in development at Forma Therapeutics, and the original cohorts are in single agent, relapse refractory single agent, and MRD positive AML, which is an interesting study. And then cohort 3 in patients who failed a prior IDH inhibitor. Those are largely enrolled, and the combination arms combining azacitidine with FT2102 in treatment naive patients who failed prior HMA, and then in the third cohort, cohort 6 at the bottom there, patients who failed prior IDH inhibitors. So this will be very interesting to see the results of this study presented next year at ASH and thereafter. I'll just point out this poster by Chaturvedi and colleagues. This is an in vivo murine experiment which showed a resolution of leukemia in mice which were transplanted with human leukemia, and a return of the leukemia with the removal of the IDH1 inhibitor, except when given together with azacitidine. So the IDH1 inhibitor that's farthest along, as I mentioned, is a drug called ivosidenib, also known as AG120. And this data was presented by Courtney DiNardo at ASH last year. Essentially, patients were escalated who had IDH1 positive heme malignancies, like the enasidenib trial, and expansion was similar with the relapse refractory second relapse arm, untreated AML not eligible for induction chemotherapy, and other non-AML relapse refractory cases with IDH1 mutation. And you can see in the baseline here that this is similar to the enasidenib trial. There were a similar number of men and women. Most of the patients, as noted by the design, were relapse refractory AML and pretty good performance status. It's probably worth noting that a fair number of patients had a prior transplant and relapsed, and greater than half the patients had abnormal cytogenetics at screening. The treatment emergent adverse events with ivosidenib are similar to enasidenib, although there seems to be a bit more of the leukocytosis. And as I was reminded yesterday, grade 3 leukocytosis is a white count of 100,000. So this is not a PI3 kinase demargination phenomenon. This is a real leukocytosis with potential leukostatic phenomenon that needs to be watched very closely in the differentiation effect. It's like tumor lysis syndrome. It's a good thing to have when you're treating ML, but you got to be careful of the downstream effects. So these patients, a quarter of the patients having lower grade leukocytosis dyspnea, but 15% of patients with considerable white count, 5% of patients with dyspnea, and a smattering of folks with arthralgias. Courtney was kind enough to supply this slide where you can see in the first cycle that and we have the luxury of a clinical trial looking at these cells in the bone marrow, which we normally wouldn't do in clinical practice at day 15 in a non-intensive chemotherapy. But you can see that the blast count went down dramatically by 15 days in that patient. And the CR rates are not striking, but they're significant, with about 15 to 20% of patients in CR. And then an overall benefit rate, which is about 30%, including these patients with MLFS or marrow CRs and PRs and CRIs. But you can see from last year, all these CR patients at the top of the swimmer plot continuing on therapy at over a year to 2 years. So there are several future studies planned. There's one study with IDH inhibitors plus 7 and 3 that we're presenting also on Monday. This study is over half accrued already, but there are a variety of other IDH sponsored and investigator-sponsored studies ongoing that will be presented at this meeting and others. IDH inhibitors are oral drugs, so it's very attractive to combine these with other agents, including venetoclax and FLT3 inhibitors like gilteritinib, as noted here. And though I didn't present the MDS slides, as I pointed in the beginning, IDH mutations are seen in patients with MDS and MDS-MPN, so I'd like to make the shameless plug at the end of my talk for the MDS-MPN IWG study, abnormal marrow, where we're attempting to actually test some of these new compounds in patients who don't really have any labeled therapy available to them. These are patients with CMML, atypical CML, mild MDS-MPN-U, and MDS-MPN RST or ring sideroblast with thrombocytosis. Feel free to reach out to me if you'd like to chat about the abnormal marrow study.
Hello guys, I'm happy to join you guys this afternoon. And my name is Amir Fati. I direct the leukemia program at Mass General Hospital, and I'm pleased to be here today to speak to you guys about antibody-directed therapy in acute myeloid leukemia. As has been mentioned by my colleagues here on this stage, the treatment of AML has really changed and expanded over the course of the last 10 to 15 years. And we have gained an appreciation of the complexity of the disease, both across a population of AML patients, where, as you can see here in this plot, you have more and more, even much more than this, in terms of mutational markers that we can detect in the disease across the population. But even in an individual patient, you see this extreme degree of the extreme potential for heterogeneity as there is clonal evolution and marked heterogeneity as the disease advances over its lifetime, especially as patients progress from MDS to AML or develop relapse disease or undergo the pressures of treatment. There is increasing changing and differentiation of clones underlying the disease, making its treatment potentially more challenging. It is good that we are only now appreciating many of these findings, because it's really impacting our ability to design more effective therapies. So in summary, AML is a highly heterogeneous disease with generally poor outcomes, despite the advances we've had over the course of the last decades. And there are certain groups that continue to have even worse outcomes, such as older patients or those patients who have secondary AML, such as AML arising out of prior myeloid neoplasms or as a result of prior chemotherapy or radiation. Conventional therapies have largely remained unchanged over the course of the last 10 years, although I have to say in the last year we've had a rush of approvals which in some ways has changed our conventional approaches. Improvement in outcomes have been mainly related to advances in supportive care over the course of the last few decades. And I'm hopeful that with the recent approvals that we have, the availability of targeted therapies, that there will continue to actually be significant impact on the outcomes for our patients. Nevertheless, novel and effective diagnostic, prognostic, and therapeutic approaches are still very much in need. Today I was going to talk to you about the antibody-based approaches targeting the proteins on the surface of leukemic cells as a way of effective therapeutics in AML. And there is now a series of targets that have been identified on the surface of leukemic blasts. CD33 and CD123 are perhaps the farthest along in drug development, but CD45, CD47, CLL1, others are not too far back. Many of us are aware of gemtuzumab ozogamicin, which was regained its approval in the last year for use in various settings in AML, both in the upfront setting in combination with chemotherapy and also in the relapsed and refractory setting. So there is a great deal of enthusiasm and excitement around these novel approaches to the treatment of AML. So let's talk about CD33 first. CD33 is a cyclic, and I don't know if I'm pronouncing that correctly, but sounds right coming out of my mouth. It's a sialic acid-binding immunoglobulin-like lectin family of receptors. What's important is that its expression is increased in cells of myeloid lineage, and particularly leukemic and also, to a certain degree, normal myeloid blasts. It confers a negative regulation on activated cytokine receptors, among other aspects. And also importantly, for the design of therapeutics, it undergoes endocytosis once it is engaged. The expression on the surface of leukemic blasts is highly variable, and that is becoming increasingly relevant. And it may be more preferentially expressed on leukemic stem cells as opposed to normal hematopoietic stem cells, although it does exist in several populations of early myeloid progenitors. The first antibody, or among the first generation of antibodies that was developed to target CD33 was lintuzumab. It was a IgG1 humanized naked antibody. It wasn't bound to any toxic agent. And by itself, it had limited activity. So a rate of response here we have among the 50 patients or so that was studied, only 3 had some degree of response. So this is reduction in marrow blasts that was noted. And because of a lack of significant benefit compared to conventional therapies over time, this particular agent, the interest and excitement around it waned. And the lack of efficacy was explained in various ways, but possibly due to the rapid internalization of the antibody-antigen complex and other potential effects in terms of inhibitory immune molecules that may have dampened its single-agent activity. Not too long after that, gemtuzumab ozogamicin, which is actually, it's not a naked antibody, it's an antibody-drug conjugate and a CD33 antibody bound to calicheamycin, a highly potent cytotoxic agent. Calicheamycin is hydrolyzed in the lysosome once the CD33 antibody complex is internalized and leads to fairly immediate cell death and actually a certain degree of tumor lysis. It gained accelerated approval initially based on a fairly promising response rate among relapsed refractory patients by the FDA. This was in 2000, so can't believe it, almost 18 years ago, or slightly less than that. But almost shortly thereafter, it was encountered significant challenges in terms of hepatotoxicity and sinusoidal obstructive disease, and there was a number of questions about whether the dose of the agent was too high, and I'll talk about that briefly here. So sinusoidal obstruction syndrome is a syndrome that is clinically very similar to veno-occlusive disease. And at least in the initial studies that were done, it was seen only in a small percentage of patients. But subsequent studies, especially in patients who had either undergone an allogeneic transplant or went on to receive an allogeneic transplant with myeloablative regimens particularly, found a fairly high clip of SOS, as you can see on the right column. There, very large proportion of patients experienced this, and many times this was clinically impactful and too often lethal. And as a result, over time, there were attempts to manage the dosing and the scheduling of the drug. So the mechanism of action for sinusoidal obstruction syndrome is unclear. There is some speculation that it may be related to a damage to sinusoidal cells within the liver related to calicheamycin as a result of leukemic infiltration of the liver. There are others who believe that there is actual uptake of the antibody drug complex by the Kupffer cells within the liver that might cause it. There might be receptor-mediated uptake through hepatic cells with CD33 expression, so a direct targeting of CD33 expressing cells within the liver. That is still very much under discussion regarding what the exact mechanism is, but it is real, and it seems to be associated with higher doses of the drug, and specifically associated with myeloablative regimens and allogeneic stem cell transplant. A large study, SWOG 0106, looked at approximately 600 patients and compared cytarabine daunorubicin induction with that combination with gemtuzumab ozogamicin, and there was no difference in overall survival in this SWOG study. Not only that, there was an increase in therapy-related mortality in the arm of patients who received GO. As a result of this, and also the increasing appreciation of hepatic toxicity, ultimately the drug was voluntarily withdrawn from the market, and there was ongoing discussion about whether the dose was too high. Not long after that, a series of studies looked at alternative dosing of gemtuzumab ozogamicin, the most prominent of which was perhaps the Alpha 0701 study that looked at newly diagnosed patients between the ages of 50 and 70, and instead of giving the dose up front in one large dose, did fractionated dosing of 3 milligrams per meter squared on days 1, 4, and 7 in addition to chemotherapy. And at least initially, they reported an improvement in overall survival, but subsequently it was only a difference in EFS that they reported. There was also additional studies that looked at untreated patients who received monotherapy with gemtuzumab ozogamicin and found some promising findings in terms of overall survival. And finally, there was a series of additional studies that compared GO with chemotherapy versus without, and a meta-analysis that was recently published in Lancet Oncology looked at 5 randomized controlled trials that compared GO plus chemotherapy versus chemotherapy alone, and found that the predominant positive impact on survival seemed to be in patients who had favorable risk AML, such as those individuals who had core binding factor AML, although there was also a slightly positive impact on survival in intermediate risk AML patients, but none in patients who had poor risk AML. Based on the composite degree of data that emerged after the withdrawal of GO into more than a decade ago, in September 2017, the FDA actually approved this agent again for the treatment of newly diagnosed CD33 positive AML or relapsed refractory CD33 positive AML, as well as in pediatric patients. So that was very exciting. A cautionary note, another drug, vadetuximab talarine, another antibody drug conjugate combining a cytotoxic agent, not calicheamycin. This was pyrrolobenzodiazepine, PBD, very potent, highly potent cytotoxic agent bound to a CD33 targeting antibody. And similar to gemtuzumab ozogamicin, this anti-CD33 antibody is bound with cleavable dipeptide linkers. It's highly stable in circulation and binds this CD33 cell surface protein, gets internalized, trafficked by lysosomes. The toxin gets released and ends up causing a cross-linking of DNA and damage to DNA and subsequent highly effective cell death. Vadetuximab talarine demonstrated single-agent, highly cytotoxic single-agent anti-leukemic activity with 47% of patients achieving blast clearance at a dose of 40 micrograms per kilogram. And at that dose, the composite remission rate was 41%, which again, compared to historical data with gemtuzumab ozogamicin, was around the same range, perhaps even a little bit better. This is the post-baseline bone marrow blast reduction. As you can see, this waterfall plot, you see this marked reduction in marrow blasts in the large majority of patients across a variety of doses of vadetuximab talarine. And this actually ultimately led to several additional cohorts of patients being studied combining lower doses of the drug with hypomethylating agents. Initial data among a handful, not a handful, actually dozens of patients showed a very promising remission rate for upfront AML, specifically among older patients or those who would not otherwise tolerate induction chemotherapy when you combined this antibody drug conjugate with HMA. But unfortunately, a phase 3 study that followed comparing the combination of HMA with vadetuximab talarine with HMA was suspended because of tolerability concerns in patients receiving the combination. So let's talk about a practice point. So Helen, 51-year-old female with de novo core binding factor AML. Mutational testing does not detect a FLT3 mutation. We know that the patient is CD33 positive based on immunophenotype, and the patient is eligible for induction chemotherapy. Based on what we know, this seems to be an optimal patient to potentially receive the combination of 7 and 3 plus gemtuzumab ozogamicin, specifically given in fractionated dosing on days 1, 4, and 7. And thereafter, you could potentially consider giving consolidation using the paradigm provided by Dr. Castaigne and colleagues in the ALPHA study. However, consolidation in the States oftentimes varies, and that's actually a point of significant discussion. It's important when you give the drug that you pre-medicate with corticosteroids, acetaminophen, and antihistamines, given the propensity for infusion reactions. And it's also important, given the challenge of sinusoidal obstructive syndrome, similar to VOD, that these patients be followed very closely for any hepatic injury following administration of gemtuzumab ozogamicin, although at this, with this form of dosing, the rate of VOD is quite low. Another case, 57-year-old patient in first relapse. Again, no FLT3 mutation, complex karyotype, CD33 positive, relapse after remission, a fairly prolonged remission following upfront induction chemotherapy. Certainly this patient may be eligible for single agent fractionated dosing of gemtuzumab ozogamicin. Another patient, a 62-year-old, achieving remission again with induction-based chemotherapy, but experienced early relapse, transplant eligible. This patient may be eligible for clinical trials that look at various antibody strategies, which brings me to CD33 radioisotope conjugates. These drugs are studied as potential conditioning regimens, so there is a few here that I will briefly mention. Lentuzumab, which I mentioned as a naked antibody, can be bound to iodine-131. There is also another compound bound to an alpha-emitting particle, actinium-lentuzumab. There are concerns regarding myelosuppressive effects, but there is relatively limited non-hematologic toxicity. AC lentizumab with the low-dose Ara-C in older patients has already been presented a couple of years ago at ASH. The radionuclide emits 4 alpha particles linked to an anti-CD33 antibody. The fractionated dosing combined with low-dose Ara-C among older patients over the age of 60 seems to suggest a dose responsive decrease in marrow blasts in patients who receive this over time. Here you see the rates of response. They're relatively modest in terms of dose levels over time, but there is actually an update this year looking at actinium-lentuzumab monotherapy, not in combination with low-dose Ara-C in older patients unfit for induction chemotherapy. CD45, another cell surface protein that is present in a variety of hematologic malignancies, but also acute leukemias, including AML, can be bound to beta radionuclides. So IOMAP-B combines anti-CD45 monoclonal antibody targeting lymphohematopoietic cells. It offers target-specific ablation as a conditioning regimen as opposed to non-specific whole-body radiation. And this could be a potential way to condition patients prior to transplant. And there have been a series of studies that have looked at IOMAP-B with reduced intensity conditioning in patients who are older. These patients have perhaps advanced disease or refractory disease. They receive this targeted radiotherapy conditioning in addition to fludarabine and modest total body irradiation. And at least in the phase 2 data, 86% of patients with AML or MDS with increased blasts had a very high rate of response and engraftment by day 20. In the phase 2 study, this data is provided in diagrammatic fashion here. At 1 year of receiving this conditioning with IOMAP-B, followed by reduced intensity transplant, 41% of patients were alive, and the rate of relapse was 40%. There is now a phase 3 Sierra trial that is ongoing and accruing and comparing control arm chemotherapy for patients who have refractory AML or relapse after first remission, comparing standard chemotherapy with IOMAP-B with reduced intensity conditioning and transplant. Other antibody targets. So CD123 is also known as interleukin-3 receptor alpha chain, is a key mediator of cell proliferation, differentiation, and survival. It is thought to be increasingly present on leukemic stem cells, but perhaps to a lower and lesser degree on normal hematopoietic stem cells, and may be a good target for development of antibody drug conjugates and other targeted approaches. It is expressed on the bulk of myeloid leukemic cells, and here is a list of several drugs that are under development or in clinical trials that are looking at CD123. I'm personally familiar with the compound from Cytogenetics. It's an antibody drug conjugate, but other companies, including MedImmune and ImmunoGen, are looking at other potential approaches, specifically with antibody drug conjugates and also biallelic targeting agents. CD47, the don't eat me signal. So CD47 is expressed on cells that tell the innate immune system, specifically macrophages, not to consume them and destroy them. So certain malignancies, including AML, are thought to increase the expression of CD47. So if you have an antibody, specifically a naked antibody that binds it, you allow the macrophage to actually eat that cell and eliminate it. I'm aware of 3 separate industry teams that are developing anti-CD47 antibodies for clinical development in AML. CLL1 is a novel AML-associated stem cell surface protein. Expression is associated with a higher rate of relapse. The BITE agent, which may be alluded to later, MCCLA-1117, is under preclinical study. So final thoughts in my last 20 seconds. There are multiple targets in AML, including CD33, the most prominent one, CD123, CD47, CD45, as well as CLL1, as well as others I will briefly allude to in the next slide. Gemtuzumab ozogamicin has been the most extensively studied in clinical trials, as everybody is well aware, and was recently approved in multiple settings in AML, including upfront with induction chemotherapy, as well as in the relapse refractory setting. Radioimmunoconjugates, as well as other antibody-drug conjugates, have been developed to target CD33, CD45, and CD123, and initial targets and modalities are also under study. Here's a list of phase 1 studies that are looking at various patients with AML. These include Cytogenetics, CD123, compound from ImmunoGen, one from MedImmune that actually is also under study in relapse refractory hematologic malignancies. The Camellia study, as well as a phase 1 study by the company 47, is looking at a CD47 antibody in AML and the high-risk MDS. And finally, actinium lintizumab is looking at a radioimmunoconjugate therapy for older patients with AML. So thank you so much for your attention. I appreciate it.
Okay, thank you very much, everybody, for staying here. And I guess you can't go anywhere anyways because it's snowing outside, but thanks anyways. So I think I have my task cut out. We saw that there is a lot of knowledge to be gained, so hopefully this will be the most educational session for you all at ASH. So let's go over where we're going, and I'm going to focus on 3 different things. So immune checkpoints, which is going to be the bulk work because we have clinical trial data there, bispecific antibodies that Dr. Fatih alluded to, but I will talk about more. And then just a brief mention on CAR-Ts, which are very, very early right now in AML. So this is an example of a patient, somebody we would see very frequently in our clinics at MD Anderson being referred to us. 69-year-old relapsed AML, has got ASXL1 TET2, so nothing targetable, does not have a FLT3 mutation, has had prior treatment with induction chemotherapy, has good performance status, no leukocytosis, and he has come specifically after going online and hearing about immunotherapy to see if there's anything in leukemia that we could do specifically in AML. So we have, and many other groups across the country, as well as in different countries, are doing a number of trials with different immunotherapies. With PD-1 inhibitors now there are, or CTLA-4 inhibitors, there are actually about 35 ongoing trials. And then there are a number of bispecific antibodies with one of them actually now showing signs of efficacy will be presented in oral at this ASH. And then there are others, 7 or 8 other bispecific antibodies. And then the first CAR T cells have just started, but very few patients, so we're not really ready to discuss those here. So the question is, why are we excited about checkpoint inhibitors? So this graph will show you why the interest. So there have been 24 approvals for checkpoint inhibitors in the last 8 years across different malignancies. So the question is, are they going to work in the heme malignancies? Of course, there's data now in lymphoma. There were signals in myeloma, although that has been put in jeopardy because of toxicity, so we'll have to see. But I think at Anderson, we're very, very excited. We're doing a number of trials with these because we think it will be a major aberration if there's no activity with these agents in one of the malignancies. I think the key here is to find out how we can get these drugs to work. It may not be single agent. It may be combinations. And secondly, can we find a genomic signature that helps us select these patients? And I think that really is going to be critical, just as molecular treatments have been developed. So here's some data which will be presented as an oral presentation tomorrow by one of my fellows. This was done in collaboration with our immunotherapy platform at MD Anderson, led by Dr. Jim Allison and Pam Sharma. And one of the questions we had is, what is going on in the bone marrow in AML? There have been hundreds of publications looking at the molecular landscape, the tumor microenvironment, but there's very little actually out there regarding the immune system. So the first question is, do we have T cells in AML? And if we do, what is the nature of these T cells? Are these inactivated? Are these activated phenotype? And then what, if any, checkpoint pathways are expressed so it can help us then direct our attention towards those? Is it PD-1, CTLA-4, OX40, ICOS? There are multiple now in clinical trials. And we're further deepening this by using mass cytometry or CyTOF, which is a very broad or more powerful version that can look at 40 to 45 markers at once and help us understand associations between tumor cells, tumor microenvironment cells, as well as the immune cells, which is very important. So some of the highlights of the findings we found, I'm not going to go through the whole presentation, but it will be presented tomorrow, is one is T cells are definitely present in patients with acute myeloid leukemia. So as you can see here in this graph, if you look at the CD8 T cells, in blue are the healthy donors. These are samples that we purchased from healthy donors, and then in red and green are the patients with AML. And what you can see here is that the CD8 T cells actually are increased in patients with AML. Again, very similar to what you would see in solid tumors, but not to the same degree of the immunogenic solid tumors like melanomas or lung cancer, where you have a much more potent infiltrate. But interestingly, Tregs are also increased, and that's an important point because one of the mechanisms of immune suppression, and other groups a few years ago have actually published that this could be one of the markers that is associated with outcome and survival post-transplant. So we did see that the T cell population seems to be preserved, and there is a increase of the CD8s as well as Tregs. And what was interesting is when we looked at the markers on these, we saw that these were activated cells. So the CD8s frequently were expressing HLA-DR, CD69, OX40 activation markers, which were not seen in the healthy donors. But what we saw is when we looked at 8 or 9 different immune checkpoint pathways, the ones that were most potently expressed were PD-1 and OX40. We did not see much of a signal for ICOS, TIM3, LAG3, GITR, and others. And of course, being in the clinical investigation area, which is where I focus my work, we wanted to see, well, if the PD-1 is truly overexpressed, can we target it? So this slide shows what we see from the PD-1 perspective. And as you can see, as compared to healthy donors, for sure on the CD8 cells, we do see more PD-1 expression. It's seen both in the relapsed patients as well as the new diagnosed patients. But we also see it on other subsets, including CD4 and Tregs. So one would say, well, how does this compare to the tumors where we know PD-1 inhibitors, CTLA-4 inhibitors work as single agents, such as melanoma, lung cancer? And it is much lower. This is not, you see 90, 100% of the cells in melanoma, lung cancer, CD8s expressing PD-1. But this compares to some other tumors where we're seeing a similar scenario that single agents doesn't work, but combinations work, such as with mantle cell lymphoma, follicular, diffuse large B-cell, and multiple myeloma. So this was one of the hints that we have some evidence of immune infiltrate, increased PD-1 expression, but it may not be enough to get single agent activity. And in this slide, we have some of the preclinical data that led to this. So there actually have been mouse models done by Tom Gajewski and his group showing that both PD-1 and a couple of other immune checkpoint pathways, CTLA-4, TIM3, could be used to decrease AML tumor burden and improve survival. There actually have been 2 small phase 1 studies. One was with a PD-1 inhibitor that was a basket study with all hematological malignancies. And what it showed was both in AML and multiple myeloma as a single agent, PD-1 inhibition did not have any activity. There were only 10 patients in that, but the bottom line was it didn't work as a single agent. Now with IPI, which is quite interesting, which is a CTLA-4 inhibitor, there was a recent New England paper published about a year ago by a group at Dana-Farber, which showed that a single agent IPI in a post-transplant, multiply relapsed population could actually produce complete remissions in 5 out of 12 patients. These had had a median of 4 prior salvage treatments. So this was very interesting signal and actually got this paper into New England Journal. And so there has been now growing data that as a single agent, PD-1 doesn't work, IPI may have activity, but the key is we probably need to take the lead from multiple myeloma or lymphoma and develop rational combinations. And that's really kind of where we're at. So one of the drugs that we use across the board is azacitidine or decitabine. We use this in frontline in MDS, high risk. We use this in frontline in elderly AML. And frequently we turn to this or other newer hypomethylating agents such as guadocytabine in the salvage setting. And interestingly, there is a lot of data, and this finding was actually done by serendipity. So it was a lung cancer group actually that noticed that there were a group of patients who were on a phase 1 study of azacitidine. This was Steve Balin's group, who failed azacitidine, did not work in those patients, and then they were scattered to other phase 1-2 studies. And 10 of them happened to go on to studies with other PD-L1, PD-1 inhibitors, and 8 of 10 responded. So Steve Balin and his colleagues, after this clinical observation, went back to look at these patients, and they found that when they had come off AZA and gone to the PD-1, PD-L1 studies, they had very high expression of PD-1, PD-L1, more than other lung cancer patients. And indeed, azacitidine, if you look at the published literature, there are lots of papers showing that it has multiple effects on the immune system. So it has favorable impacts, such as increasing exposure of cancer testis antigen. There's some updated data here. Increased MHC expression, which the group at Roswell Park has shown in a recent poster at ASH last year, as well as increased co-stimulatory markers, CD28, others. but at the same time it does some negative things, which is it can increase PD-1, PD-L1, CTLA-4, which Steve Balin's group showed, and then we saw this in MDS. So the question is, how do you use these drugs where you may continue to get their favorable inflammatory or interferon gamma upregulating signature while avoiding the abrogation that happens through upregulation of PD-1, PD-L1? So this was some of the data that Dr. Garcia-Monero and his lab from our group had published a couple of years ago, showing that in people who get HMAs, if you look at the first top right figure, these patients, when they are on the HMA therapy, have an increased expression of PD-1, PD-L1. What's interesting is that it was reversible, and you see the maximum expression somewhere between day 10 to 20. What was interesting that it had a clinical correlation. So those who had the highest upregulation of PD-L1 and PD-1 seemed to be the ones who did not respond to the HMA treatment and also was associated with inferior survival. So this led to the hypothesis that maybe this is one of the pathways of resistance, or at least that we may be able to combine PD-L1, PD-1 inhibitors with these HMAs and maybe improve response rates or down the line improve survival. And so that this led to one of our studies, which has turned out to be, was started as a smaller dose finding and expansion study, but it actually turned out to be quite a large study with a number of patients on it. So the study initially started among relapsed population, as would be expected, and it used standard dose azacitidine, 75 per meter square days, 1 through 7, repeated every 5 weeks. And in addition, we added the PD-1 inhibitor. In this case, it was nivolumab, and it was given at the standard dose schedule, 3 milligram per kilogram, every 2 weeks, just like in solid tumors. In the first 6 patients, we saw no signs of major toxicities, and so we expanded that dose. Now we've enrolled 70 patients. The last update of this study was done at EHA meeting a few months ago, and the paper is currently in review. Based on encouraging data, we have now gone to the frontline setting, and there will be a poster that my group will be presenting on Sunday showing some of our frontline data, which looks quite encouraging. And then we're also going now to combinations with some of the newer checkpoint inhibitors. So now let's look at the data at this study. So these were 70 patients, as would be expected, not by design. This allowed any age, but we ended up with more elderly population. So the median age was 70, because for the younger, even in salvage, a lot of investigators will try higher intensity treatments, try to take them to transplant if possible. As you can see here, a number of these patients were secondary AML, about 45% of them, and then we did have 1/3 of them with adverse cytogenetics, very similar to the initial slides that Dr. Erba showed, what you see in elderly frontline HMA patients, where about 1/3 of them have complex adverse cytogenetics. We did have molecular annotation on all of these patients, and TP53, which is known to be very frequent in the elderly population, was seen at about 20% incidence, which matches with another large cohort that we have published from our group. So everything was as would be expected for a relapsed AML population. So here we look at the response rate. So the CR, CRI, PR is about 25%. Now what's interesting to us, but not really to the solid tumor groups and others who have used immune checkpoints, is there's a group of patients, even in salvage, who seem to have prolonged stabilization of disease. And some of these are now beyond 1.5 years, up to 2 years, have not had transplant, they're salvage patients, and they're doing well. But they do not clear their blast. Their transfusion requirements become less. And this is what has been seen in Hodgkin's lymphoma, where bulk of responses are stable disease or some reduction, as well as in other tumors. So we're trying to define this phenomenon, because I think with many immune therapies, this is going to be important. We may not see the typical IWG responses, but they may actually be important for survival endpoints. And this may be a new definition that we need to start looking at, just as solid tumor populations had to do when they did immune studies. The other thing to note here is the time to respond. So just as Dr. Savona mentioned for the IDH inhibitors, I think there are a lot of parallels here. We can see responses later. They may not be associated with complete clearance, and there may be things beyond CR, CRI, PR that are associated with improvements in survival. So here again, when you look at the people, the 25% who had CR, CRI, for sure you see the benefit, very similar to what he had shown with IDH. You have good survival. And then the non-responders do, as would be expected with non-responders in any treatment, poor survival. And then you have this group in the middle who has stabilization, hematological improvements, who have survival improvement. So we should not miss these population and include them as larger studies are being done with the PD-1, PD-L1 inhibitors that I will mention later on during the talk. So we did not have a randomized group in this study, but we do have very good historical controls at MD Anderson from multiple other studies that we have done with HMAs in the last few years in salvage setting. And what we usually see is in a salvage setting with an HMA, the outcomes are poor. The response rates are 11 to 15%. Dr. Zaidan and his group actually presented this as an oral last year when they took multiple salvage HMA population and showed that the response rate was somewhere around 15%, and the survival is poor, 4 to 6 months. What we saw, especially in the early salvage population, which makes sense because what I did not mention is that when we look at the T cells, they actually are very healthy in the frontline and first, second salvage, but then you start losing them after people are getting high-dose chemotherapy, is that we had an interesting median survival. Now, this salvage survival actually is comparable to what you may have seen in the frontline setting in similar elderly, high-risk populations. So it's not randomized, so we do not know if this will stand out, but I think there's definitely interest in the early salvages and frontline to see if that tail of the curve will continue to be maintained. The advantage we had in this study is we were able to get a lot of samples. We made a lot of effort to try to get immune correlatives because I think these will become extremely important to understand how we can select patients, just like we do for IDH and FLT3. One of the simple findings that we noticed is that people who have more T cells in their bone marrow to begin with are more prone to response. So it sounds intuitive, has been shown in many solid tumors, but it was good to see that in AML as well. So if you look at the first graph, those who had more CD3 infiltrate at baseline in red as compared to those in blue tended to be in the CR group. And that was again seen for the CD8 population, that if you had more CD8 in your bone marrow to begin with, that's the red population, then you had a better chance to respond. So you have more T cells, it's easier to manipulate them rather than try to mobilize T cells into the bone marrow and then get them activated. These are two additional steps. The other thing we noticed is that not only did patients have more T cells associated with response, but the T cells had an activated phenotype. So we looked at a number of markers such as HLA-DR, ICOS, OX40, these are activation markers. And what we see is that while these patients are on treatment, as you can see in the lower left graph, the people who respond, they actually have an increase in activated T cell population in their bone marrow that is not seen in the non-responders. So again, it's not just because we're debulking the marrow, getting less blasts that you have more T cells, but their phenotype is actually activated, which is important. And so these may be true infiltrating T lymphocytes. We're looking at this now with T cell receptor sequencing, and hopefully you'll have that data soon. And then the other thing is CTLA-4, I didn't mention in the beginning, it was not expressed at a high level, but we are now seeing that the CTLA-4 levels after treatment with PD-1 are going up. Again, no surprise to solid tumor oncologists, this is what they've seen in multiple tumors, but it's interesting to see that if you block one of the major inhibitory pathways also in myeloid malignancies, the other one may become important. And so the question is, could the combination be the way to go eventually? And we're getting there. This is one of the posters we have here at ASH looking at CyTOF, which is a very, very powerful tool, but requires a lot of bioinformatics. The bottom line we're seeing is that actually in AML patients, there are two flavors. There are some who are very immune activated, and they have multiple activation markers, OX40, ICOS, upregulated. And these people are primed and ready to respond to immune checkpoints. And then there's another group that have multiple inhibitory markers, PD-1, LAG3, TIM3, and they're not going to respond with single agent PD-1 or even combinations. And I think with CyTOF, we may be able to start understanding and potentially finding ways to select these patients. So toxicity is very important, and Dr. Fatih mentioned this, and so did Dr. Savona with the IDH. So there's a unique toxicity profile that we see with these agents. If you look at grade 2, 3, 4 immune toxicities, about 20% of our population experienced one of these at any time on the trial. The important thing is that almost in all cases, these were manageable with steroids and are quickly reversible within 48 to 72 hours. However, if the steroids are not introduced, we have seen patients who could progress quickly. And it may sound easy, but it's not in AML because a lot of these people come in with hypoxia, fever, shortness of breath, chest pain. And guess what? Physicians will say, well, this is leukemia with neutropenic fever and pneumonia, and the knee-jerk is to treat with multiple antifungals, antibiotics. And in many cases, we have noticed that that did not work, and we had to add steroids. So what we're doing now is in these patients, we add early steroids with broad-spectrum antibiotics. If they're improving, we rapidly wean those off. And we have not seen an increase in fungal infections. It's actually one of the things we're looking at in our manuscript. So I think it's very important to understand that. This is where our study is going now. We have now a combination. In the front line, we're doing just AZA and Nivo to get experience with that. But then we're going to be doing in salvage a doublet based on the data where we saw CTLA-4 was upregulated after PD-1 inhibition, and we're doing the same in MDS. So some of the other studies, I'll quickly go over the MDS studies. This was presented last at EHA as well by Dr. Guillermo Garcia-Manero. He took a little different approach. He looked in two groups. So frontline, he looked at combinations of AZA-NIVO, AZA-IP, and AZA-NIVO-IP in 3 separate parallel cohorts. And in post-HMA patients, which you know are very high risk, he looked at single-agent IP, single-agent NIVO, and now we're doing the combination. And these were 20 patient cohorts to see what the activity would be. And what you can see is clearly, again, AP as a single agent, just like in the post-transplant data, shows activity. And I don't show the survival, but actually the tail to this curve is quite interesting and is very encouraging to us. And then AZA-NIVO, again, in the frontline MDS, just like in frontline AML, as we will show in the poster, was showing between 65 to 70% response rates. So I think, again, when you take things frontline, you get a very different picture than the salvage. This is a study that Dr. Farhad Ravandi from our group will be presenting. Completely different approach now. We're not using HMAs. We're using high-dose chemotherapy. Was there a scientific rationale when we did this? No, we did this because chemo is what we use and we wanted to add a drug. Is there scientific rationale now? Yes. There is now data where solid tumors are showing that if you use high-dose chemotherapy, you can spread neoantigens and it may work. The bottom line is the study is showing response rates very similar to what you get with IA. However, the CR duration seems to be improved. There's a trend towards improvement, but we only have 2-year follow-up. So there are a number of trials. I'm not going to go through this list. As you can see, a bulk of them are HMA-based combinations because a number of people had the similar idea. Both clinically it made sense, and there was a lot of rationale for it. But then there are some post-transplant, which I think is a very attractive area to go. And then in MRD, we do have a trial in MRD setting that Dr. Kadiev had shown at EHA, which is very early, but there may be something there in the future. And as you can see, more trials. There are a couple of trials that I would like to point out which may help us understand better where we are. So there is a randomized phase 2 study that has just been completed with a PD-L1 inhibitor. It had 2 cohorts, about 100 patients each, randomized to either AZA or AZA plus durvalumab in MDS or in AML, again randomized. So 50-50 were randomized in each of these arms. And the study is completed accrual, and we are waiting for the results. Hopefully in the next 3 to 5 months, we may have some updates, and it'll be interesting to see what we find. So let's go to this practice point. So we have a 72-year-old with relapsed AML receiving AZA with PD-1 inhibitor. He's cycle 3, day 19, received last dose of nivolumab recently, comes to ED with shortness of breath, cough, and fever. Blood pressure is okay, pulse is okay, has bilateral opacities. What are the next steps? So you would go ahead and start these people on treatment concurrently with steroids, antibiotics, and then if they're doing better, we quickly start weaning off the steroids. And we've done this now in a number of patients with success. Again, as I mentioned, very important, pneumonitis is one of the common toxicities, but there are others. Skin rash is another one we've seen, nephritis, hepatitis. So these people need to be monitored closely. But again, I feel a lot of times that the solid tumor oncologists actually are able to do a very good job of this. And for leukemia experts, we are taking time because we have not used these for a decade like the others. So in the end, I'm just going to talk a little about the bispecific. I think this is my second last slide. There's a lot of interest among the bispecific antibodies, a lot of preclinical data. The first clinical data are actually going to be shown. There is a bispecific MGD006, which is a DART that targets CD3, CD123, again using your own T cells to fight against leukemia cells. And they are now seeing activity, 5 out of 14 responses with a single agent in salvage. And there are many others ongoing. Amgen has one. There's one with XMAB, and then there are many others, CLL1, etc. So where we are at this time is that I think with the HMA combos in frontline in both high-risk MDS and AML, we're seeing encouraging response rates of 60% and higher. In salvage, we're seeing a survival signal even without what I would consider very high response rates. Management of toxicity, I think, is going to make or break how these things go. If we can manage these toxicities, I think we will get the benefit. But if not, then these could really become a big issue. And then bispecific and DART antibodies are attractive, but very early in phase 1. So we have to wait for the data to mature. And of course, these could all be things to combine. So I think some of the directions we're looking at is doing double checkpoint, but also using some of the molecular targeted therapies such as venetoclax or bispecifics with checkpoints, and some of these trials will hopefully read out next year. And there is a randomized phase 3 study actually that is going to be starting soon, which is AZA versus AZA with PD-1 nivolumab or AZA midostaurin. So that'll hopefully give us answers, and I think it's planned to start with the SWOG group next month.
Okay. As you might expect, any symposium that includes me as one of the speakers, we are running behind. But we've been given permission to go till 3:40. But still, what I'd really like to prioritize are the questions coming through, because what I see up here with my colleagues are people who treat AML every day, and the questions coming through are incredibly practical. So I want to spend a lot of time there. This last segment is really looking at new molecular targets in AML, and I hope you will bear with me, because I'm really not going to be able to do this section justice. I mean, if you just look at this slide, this is a very limited list of some of the agents in development, and we've listed it this way just because the top 3 or 4 are ones that are a little bit further along in development than anything else on the list, and anything below the list that didn't even make it. And what I'm going to do is I'm going to take the chair's prerogative and focus on venetoclax, since it's a commercially available drug, and there's a lot of talk out there about its activity in a variety of malignancies, but especially in AML, and then mention very quickly glastigib, pevonedistat, and selinexor. So we're going to start with the 75-year-old man with de novo AML. He has congestive heart failure, real congestive heart failure requiring treatment, but he has adequate renal and liver function and an adequate performance status, presents with a high white count, thrombocytopenia, and anemia, no FLT3 mutations. So the patient's ineligible for induction chemotherapy due to the history of CHF, and so we would consider for this patient lower intensity therapy, and also this patient would be a candidate for a BCL2 inhibitor, an HMA, as an option. So that's what I want to focus on, and then we'll go quickly through the others. I'm not going to belabor the basic science behind all of these drugs. I'm probably not the right person to do it anyways, so since I'm very much a clinician now. But we know that venetoclax is an inhibitor of BCL2 and can activate apoptosis. So Clonopeleva at MD Anderson led a phase 1 study as a single agent in AML, found a response rate of about 19%. This then, of course, led to combinations of this drug with other things that we have in our armamentarium, the HMAs, low-dose cytarabine. So here is venetoclax in a dose escalation with either decitabine or azacitidine. You can see an overall response rate of 62%, with many of those being CRs and CRIs. And you could see this little swimmer's plot. I'm not sure I can make much more out of it than that. There's a swimmer's plot. Okay. Let's move on. Venetoclax and low-dose cytarabine in patients over the age of 65. This was presented at ASH last year. It's going to be updated this year at this symposium. Again, a phase 1 design, venetoclax at increasing doses with low-dose cytarabine, and then it led to an expansion at the recommended phase 2 dose of 600 milligrams. You can see the eligibility over 65 and in some way not eligible for standard chemotherapy, with an overall response rate, again, of 70% in patients over the age of 75, pretty respectable. Secondary AML, overall response rate of 52%, adverse karyotype, 47% of those patients. All 3 of the FLT3 mutated responded, and another thing that people are wondering about is this activity in the small number of patients with IDH2 mutation, 5 out of the 7, and you can see that the probability of survival there, 54% in this group of patients. And I'm going to move on then to just the survival curves, which are shown here. And again, on the right, responders clearly doing better than non-responders. You see the overall survival in all patients. And the problem with this is that it's still a very short follow-up, and I think we need to take that into consideration. And we also have to keep in consideration what toxicity venetoclax may potentially add to a therapy that you're giving to patients who are not fit for standard treatment. There is an ongoing phase 3 study now of venetoclax with azacitidine in newly diagnosed AML patients. You can see the dose that's being combined is 400 milligrams once daily of venetoclax versus placebo with the standard dose of azacitidine. So there's been a lot of interest in looking at that combination of venetoclax with HMAs, low-dose cytarabine, very, very intriguing high response rates. I think the follow-up is short in terms of really getting an idea of the benefit in terms of durability of responses, overall survival. A few other drugs that are in development and pathways that are being targeted. Glastigib is an inhibitor of the Hedgehog pathway, which is important in maintaining stem cellness. This study created a lot of attention last year at this symposium, this Congress, where low-dose cytarabine was combined with either Glastigib orally or not a placebo. And there's a very impressive survival benefit. That's overall survival with a median survival of 8.8 months versus 4.9 months for the low-dose cytarabine with a hazard ratio of 0.5 and an incredibly low p-value. Now, if you look at subsets of patients, the benefit was also seen in the bottom there in the patients with poor risk cytogenetics. But one thing that makes you wonder about the design here is that when you look at the response rate with low-dose cytarabine and Glastigib was what we would expect with low-dose cytarabine. Many studies over the past several decades have shown response rates in this 20% range, not too dissimilar from the HMAs, and really much lower response rates in the low-dose cytarabine arm alone, not what we'd expect, right? We'd expect something higher. And so it makes me wonder about the design in the sense that you have an older patient at a major medical center going on a study with a interesting new drug, but you know the patient's not on the interesting new drug. How long do you keep them on low-dose cytarabine before you think of other options for the patient? I think we can only address this kind of issue when we have blinded studies. Two other drugs that are being developed, pevonedistat is a NET8 activating enzyme inhibitor. NET8 activating enzyme is high up in the proteasome pathway, and this is data that a number of us have helped generate here on this panel, but Ronan Soares from the University of Miami has presented last year at ASH looking at the combination of pevonedistat with azacitidine, and again you can see a very high response rate in this watershed plot, and this combination of pevonedistat and azacitidine is being studied in a phase 3 study versus aza alone in high-grade MDS and low blast count AML. And then finally on the list, selinexor, which is an inhibitor of XPO1, so it affects nuclear transport. There have been single-agent studies, phase 1 studies showing some response with acceptable tolerability in those phase 1 studies. So obviously moving on then to combinations, that's what we do, right? Selinexor now with idarubicin and cytarabine, and here's data that's been presented along those lines as well. So I apologize for going quickly through those, but I really think that the audience has been very patient with us and have a number of great questions, so I want to come to those. So we have a number of questions. I'm going to pose them to people in the group, and let me go down to some of the first ones. So one of the first questions that comes up is, what do you do when you have opposing molecular data in terms of prognosis? So the example that was brought up is there's an 821 translocation patient. There's no c-KIT mutation, but there's a FLT3 mutation. How do you transplant that patient, or are they low risk? So what do you do with molecular data? We'll focus on CBF translocations. How does it affect your treatment? You want to start, Steve?
Sure. So, I think that there's a fair amount of data that the presence of FLT3 in these patients, it does confer a poor prognosis. However, we don't have a lot of data about what to do with that information and whether or not those patients get a significant benefit from taking a transplant. I think it makes us uncomfortable. There is some pediatric data that does indicate that the presence of that abnormality in this population confers that prognosis, but there's also adult data which says it doesn't have as much of an impact. So I think the question is still out there to be answered.
Yeah, I agree. There's data from Europe looking at the CBF translocated patients and c-KIT mutation does increase the risk of relapse in their data set. But what was interesting was the interaction then with tyrosine kinase mutations, FLT3 and otherwise, which really increases it. So maybe the combination is even worse, but FLT3 on its own, I'm not certain. And in my own clinic, for a patient with a CBF translocation, I typically reserve transplant for relapse with the argument that I typically have an easier chance of getting that patient into a second remission, then transplanting them, and I don't really know how to use this data to decide who should get a transplant in first remission. Any takers? Agreement? Okay. This really has to do with what we've been talking about, and it's probably the most important question we were trying to decide is, okay, we've looked at all this data of on-label drugs that have been approved for AML, and then there are drugs out there that are approved for other indications but are commercially available for our use. So, which of the new therapies covered in this talk should be considered as now new standards for patients who meet the indication? I mean, which drugs are we moving now into our treatment programs? Amir?
So I think in terms of, there's been 4 new drug approvals this past year, and perhaps a couple more that are likely coming along. For me, I do incorporate midostaurin in patients who have FLT3 mutated AML in the frontline setting and combine it with induction chemotherapy. IDH inhibitor enasidenib, certainly for patients who have relapse or refractory IDH mutant AML, I think it is also, that too is also appropriate in that setting as well. I think gemtuzumab is a little bit more challenging, I think for the reasons that were mentioned here in terms of most of, at least the composite data seems to indicate that the survival advantage in the frontline setting is in the favorable risk core binding factor perhaps, and to a lesser degree in the intermediate risk AML population. As of right now at our institution, we are trying our best to find areas where we can incorporate gemtuzumab ozogamicin and focusing that specifically in favorable risk AML patients. Finally, CPX-351, we, at least where I am, we are using that in patients who have secondary AML or patients with AML and prior MDS between the ages of 60 and 75. So yes, we are incorporating all of these at various paces in our patient populations. Now to your earlier question as to what do you do when you have multiple targets? I don't know if anybody has a correct answer to that, and I think for us, each patient is an individual decision that makes the best sense for that patient and their goals in terms of treatment.
Okay, but I'm going to put you on the spot because that's what they want to know, right? So you have a patient who's 65 with secondary AML, and you've decided to, on-label, give them CPX-351.
Right.
Okay, the FLT3 mutation comes back. Will you or won't you start midostaurin?
What I would personally do is I would not give the patient midostaurin because midostaurin has been combined with 7 and 3 in the clinical trial that led to its approval. But I might consider using sorafenib if that patient, I shouldn't have said that, FLT3 inhibition following transplant if that patient ultimately goes to transplant. But I do not think I would combine FLT3 inhibitor with CPX-351.
Anyone?
Yeah, and I think that's very controversial. I mean, I think there are a lot of people who would side with Amir for sure on this. I think there are folks who might split hairs a little and say there hasn't been a study of FLT3 inhibition with CPX-351, but this is daunorubicin and cytarabine, come on. So, once the drugs are out of your system and you're not giving them at the same time, but you're giving this on day 8 through 21, it seems like a reasonable thing. I think clearly giving a FLT3 inhibitor with gemtuzumab or some of the other drugs, that's probably a little more controversial. But giving the FLT3 inhibitor with CPX is something that's probably more controversial.
And how about, just to throw it in there, a normal karyotype FLT3 mutated, you've given them 3 and 7 and GO, and then you find out they're FLT3 mutated. I'm sorry, would you add in midostaurin there? Or are we all waiting for the data?
I think the more complicated you make, the more controversial it gets.
Yeah.
You know, and I tend to stick to the study populations as much as I possibly can and the FDA approvals. But that's just, I completely agree with Michael. I mean, there is lots of controversy here, and you cannot necessarily fault a person who adds a drug in a patient that has a targetable lesion.
Yeah, I guess I think the question you're asking about gemtuzumab, I think there's more of a safety concern in induction, but as Amir was saying, you could vote to not introduce this without the study data to back it up, but in consolidation, maybe it may be something that you could justify. And I think another thing that the elephant in the room is really the whole medical economics of this. It used to be that docetaxel wasn't approved for X, but you could write it because it cost 35 cents. And now you have a drug that has a single approval in 17p deleted CLL that may seriously affect your hospital reimbursement or whether or not the insurance company will pay for it. So I think it changes the conversation quite a bit. And I hate to say it, but this is the reality of practicing medicine this day and age.
So let's do a few practical questions I think we can knock off quickly here. One question is FLT3 testing. Should you only do that in patients with normal karyotype? Or should you do FLT3 testing? You have a 55-year-old with newly diagnosed AML. FLT3 testing at the time of diagnosis or reflexive to the cytogenetic testing?
I would do the FLT3 testing for everybody across the board. I mean, it's less common, but there are patients with complex cytogenetics, TP53, who have FLT3. So, and if they do, then I would consider FLT3 inhibitor therapy. So,
yeah, FLT3 is one of these late mutations that comes and goes, and I've seen it across this sort of the breadth of AML. I had a patient not too long ago who had MDS with excess blasts, went to transplant, and relapsed with fulminant FLT3 mutant AML that was not detected earlier. So I think FLT3 specifically is a test that I pretty much do across the board when it comes to AML patients at diagnosis.
Well, in fact, we've published, as many here have also seen, that you can actually acquire FLT3 at relapse, even if you don't see it at diagnosis. It's about 10 to 15%. So in fact, FLT3 is one of those that we check at diagnosis relapse, and I have a number of patients who did not have it initially, acquired later, and now are eligible for targeted therapy on trials.
And
with
vice
FLT3
versa,
inhibitors.
Sometimes patients who have FLT3 mutant AML relapse with FLT3 negative disease. It's sort of a peekaboo mutation.
Yeah, I don't think we've seen the subset analysis of the Ratified Trial regarding the interaction of cytogenetics with the benefit of midostaurin, but clearly, in the absence of that data, I think we should assume that we should be giving midostaurin in that group. Quick question for Michael. So the patient developed an differentiation syndrome on an IDH2 inhibitor, and they're better. Now you're reintroducing the drug. Do you need to dose reduce?
How bad's a differentiation syndrome, right? I think that this is handled on a case-by-case basis. I like to hold the drug. I don't really see deleterious effect with the short-term hold of the drug. The label doesn't necessarily recommend holding the drug. It says you could hold the drug. If the patient's differentiating and the problem is fixed, then you can re-challenge with the same dose. If it happens again, I think you're forced to go back with a lower dose. Now, the question of whether you re-escalate the patient later or not is a good one. Once the patient's cleared disease, and it's worth considering, but it's also worth noting that there really isn't a dose-dependent efficacy with enasidenib from the phase 1 trial. So.
And Amir, you presented the data at ASCO, right?
Yeah, hopefully soon this will be published in terms of recommendations that we are providing for differentiation syndrome. Certainly holding the drug is not wrong, but one thing that we should keep in mind is that the half-life of these drugs are quite prolonged. So, and I think if the symptoms of differentiation syndrome are prominent enough, treating with steroids is appropriate. You can't necessarily rely just on stopping the drug and for the symptoms to go away, because they may persist and are potentially lethal. So it's important to start treatment quickly, and if things certainly persist or get worse, you have the option of holding the drug as well.
Now, a quick question. If you have a patient who's gotten a checkpoint inhibitor-based therapy and they respond, can they go to transplant? Do you send them to transplant?
Yeah. So we actually have a poster here by Dr. Oran from our transplant group. We looked at 26 patients who had either PD-1 or CTLA-4 for AML or MDS and went to allotransplant. In general, there is a signal, just as was seen in Hodgkin's lymphoma, for increased grade 3/4 GVHD. What was interesting is when we look at the post-transplant GVHD prophylaxis, and now we're getting to small numbers, but there were 14 who got Cytoxan and 12 who got other. And it's very interesting, but the Cytoxan receiving patients as post-transplant GVHD did extremely well. They've had less than 10% grade 3/4 GVHD. In fact, they look better than people who are not on immune checkpoint, and their 6-month survival is very good. So we're going to now do this going forward for all our patients, lymphoma, myeloma, who are getting transplant, and Dick Chapman and his group are going to evaluate this, because it seems that post-Cytoxan use as post-transplant maintenance seems to be okay to do the transplant.
Okay, we got 4 minutes. So 2 related questions. Are IDH mutations exclusive of FLT3 and de novo AML? So, and then what do you do if you have both IDH2 and FLT3 mutations in terms of therapy? In terms of exclusivity, you know, FLT3 mutations are often found with others, most typically DNA methyltransferase 3A, nucleophosmin, and a little bit of TET2, WT1. There are a few patients that will have both IDH mutations and FLT3, but it's a small number of patients. But the question then comes up, you have a patient with relapsed AML, okay, and they have both a FLT3 mutation and an IDH2. Give them 2 drugs, if you can find them. Give them in sequence. What sequence?
Well, I'm not aware of a FLT3 inhibitor agent that is approved for relapsed or refractory AML. We've used sorafenib in that setting, and I've used sorafenib in combination with HMA therapies effectively. But I think in sort of standing by itself, I think you're not wrong to try to treat the patient with an IDH2 mutation with enasidenib in the relapse refractory setting. The challenge with IDH inhibitors is that they don't work for all patients very quickly. It may take 2, 3, 4 months before you have optimal effect. So it may take some time for response, and obviously you have to watch for things like differentiation syndrome.
Well, and there is there are a couple of trials I think Michael mentioned that are going to look at this. So FLT3 inhibitor, gilteritinib or quizartinib plus IDH, and then venetoclax plus IDH. So I think we're going to move into this arena. You know, I think that may be the elephant in the room. Myeloma has given us an example. I think we're going to be in 2-3 years in multiple combinations, targeted therapy, hypomethylator or something, immune therapy, and that's really where it's going to go. But it has to be on trial setting so we know the data.
The right answer is clinical trial. The difficulty is if there's not an availability of a clinical trial for your patient, and it's really a tough answer in that situation, obviously.
Okay, I'm going to address maybe a couple of questions quickly. What is the role of HMA as a maintenance after induction therapy? Your patient's in first remission, secondary AML, so we'll say a poor risk AML, but you don't think they could stand consolidation or transplant. Well, actually, there's going to be data at this Congress on exactly that point, not specifically secondary AML, but it's the group from the Netherlands have looked at giving 2 rounds of induction. Patients in first remission then were randomly assigned to observation versus azacitidine maintenance therapy. So you don't know why they went on the study if they're like the patient you're asking about here, that they really truly couldn't get consolidation. But if you really have a patient who couldn't get consolidation, then what that study showed was a statistically significant improvement in relapse-free survival as you might with azacitidine, but only a trend in improvement in overall survival that barely became statistically significant when they took out the very small number of patients in the study who went on to transplant. So you can find that somewhere in the oral sessions here. How about another question? Okay, you're going to use gemtuzumab. What dose and schedule? Stephen, you want to try that?
That's a great question.
So I guess it depends on which setting, but just to tackle in the frontline setting, if you're going to use it, I would use the lower dose with the, I believe it's day 1, 4, and 7, 3 milligram per meter squared, and avoid the higher dose. I believe the data support that the toxicity and the incidence of VOD is less, and the safety profile is improved with that lower dose fractionated approach.
Okay. Question, why not azacitidine and GO and possibly venetoclax for patients not fit for 7 and 3? Actually, SWOG did that study of looking at azacitidine with gemtuzumab, 3 milligrams per meter squared on day 8. And it's phase 2 data, and yes, we got responses, but when our statisticians went and tried to compare those patients to those in the literature who just get azacitidine, it didn't appear that the truly poor risk patient, I mean, over 75, maybe poor performance status, that they were doing any better in terms of survival with the combination. But can it be done? There's data for doing that. And again, possibly with venetoclax, I would say inside a clinical trial myself, but okay. There was a question here, it's going to come up. There's a question here. Can enasidenib be safely used in the treatment of the newly diagnosed elderly patient with IDH2 gene mutation? So up front.
Data seems to suggest that the answer is yes.
It's just not on the label.
It's just not labeled and FDA approved.
Yeah.
Right.
Safe.
Would you use it alone or with an HMA?
Neither are approved for use. So if I was going to use it, I would use it alone. I think we're learning about its combination with HMA at this time. It's an active, ongoing clinical trial.
Okay. Well, I took 1 extra minute. So I'm sure we're going to stay behind. I know there were some questions. Whoever sent this question, I'd be glad to discuss the case as any of my colleagues. But again, thank you very much and enjoy the rest of your ASH.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/MJN. This activity is supported by independent educational grants from AbbVie, Actinium Pharmaceuticals, Agios, Astellas Scientific and Medical Affairs Incorporated, Celgene Corporation, and Jazz Pharmaceuticals Incorporated.